We are going live. So we are live now. Good evening and welcome to everyone. I'm Sreshi from Clanet, and Clanet is one of the largest live digital CME platforms in India where doctors can generate their medical content. Clanet is very proud to be a part as a digital partner for this event organized by Indian Academy of Pediatrics, Gujarat. And the topic of today's session is case discussion on central nervous system. Now I would like to hand over this session to Dr. Nihal Patel, ma'am. Over to you, ma'am. Kindly proceed with your talk.
Thank you, Clanet. I welcome all of you, all the PG students and mentors to our prestigious program, E-Gurukul Pathshala, the PG Clinic. Today we have a case discussion on central nervous system. And for this to present the case, we have from Institute Department of Pediatrics, Government Medical College, Surat, Dr. Saurabh Prajapati as a presenter. And I also welcome his mentor, Dr. Upendra Chaudhary, who is Associate Professor at the Department of Pediatrics. We have two renowned professors and the experts in the field for this case presentation, as the case discussion is on central nervous system. So I welcome Dr. Anand Keshwan sir. Anand Keshwan sir has given tremendous support in our this E-Gurukul. He is always there whenever we ask to join, and he is there to guide the students. Sir is a professor of pediatrics at GMC Thrissur. He is the chairperson of ECHG in 2023 and 24, IAP National Vice President in 2020, and past National President and Secretary of IAP Neurology Chapter. He is the Chief Editor of IAP TB textbook of Pediatric Radiology, Frontiers in Pediatric Neurology, and Recent Advances in Neonatology. He is a member of IAP ACVIP group and is National Convener of IAP PG Quiz Program. Welcome, sir. We also have another renowned pediatric neurologist, Dr. Ritesh, with us. So, Dr. Ritesh has done his MBBS from BJMC Ahmedabad and MD from the VS Hospital Ahmedabad. He has, just a minute, sorry. He has done his fellowship in pediatric neurology from the Hinduja Hospital and also fellowship in clinical neurophysiology from the Cleveland. He is practicing at Surat as a pediatric neurophysician since last 12 to 14 years, and he has published many papers in various journals and conferences. He has written chapters in the few books on various topics, and he is also a faculty of the pediatric epilepsy training in various state and national conferences. Welcome, Ritesh, sir. So I welcome you all in this program, and so we can start with the presentation. Dr. Baldev sir will join in a few minutes as he is busy for about 20 to 30 minutes. And I request all the PG students who have joined to please take part in the discussion so that the session will go and look live. So Saurabh, you can start the screen sharing.
For starting, very good evening, respected Yogesh sir, Nehal madam, and all other office base of E-Gurukul program. I once again thank you for inviting me for the third time. I think I am.
Yes, sir. And we are thankful that you are always ready whenever we need your help.
And my request to my students is, Saurabh, you present very boldly and without any bias. And also I request all students to open their video because all questions Saurabh are not supposed to answer. So I want all the students here. Madam told that 2 students are there. So you open your video. So it is convenient for us. Otherwise, every time we are asking question to Saurabh, it may be difficult for him and also for us also. Thank you. Yogesh bhai, thank you once again.
So Rashmi, also you can also switch on your video. So Rashmi, Aarti, Rajat, Dhaval, and Saurabh all are there, and sir, you can interact with them.
Sir is also joining. I think Ridesh can lead the discussion.
Yes, Ritesh sir.
Yes, I am here only.
Yeah. Okay.
Good evening.
Okay. So Saurabh, all the best. Start,
For
please.
today's program, all are the GMCS alumni, including Nehal Madam, VK sir, and Ritesh, everyone. Mentor Dr. Upendra also. Saurabh, unmute karo, start.
Okay, sir. Good evening, ma'am.
Good evening. Make it a full screen.
Good evening, all of you. Sir, my name is Dr. Saurabh Prajapati, second year resident doctor in the Department of Pediatrics, Government Medical College, Surat. Today we are going to discuss about neurocystic CNS case, neurocystic sarcosis under guidance of Dr. Yogesh Parikh, Associate Professor, Department of Pediatrics, Government Medical College, Surat. And my mentor is Dr. Upendra Chaudhary, Associate Professor, Department of Pediatrics, Government Medical College, Surat.
Two things, sir. First of all, you should not reveal the diagnosis. Second thing is that it's not CNS, it is nervous system.
Yeah.
We are dealing with the central nervous system and the peripheral nervous system. It may be central nervous system. This case may be central nervous system. So we are dealing with the nervous system case, and also should not reveal diagnosis. That is why first I told you don't get biased.
Okay.
Now you are going to be biased because most probably you won't get any examination findings here. I think okay, we'll proceed. Okay.
Okay. Sir, our case informant is mother presenting a case of 8-year-old female child, Nandini K. Saroj, born first in order out of a non-consensuous marriage, who is a resident of Kalika Nagar, Pandesara, Surat, belonging to a lower socio-economical class as per modified Kuppuswamy classification, admitted in Pediatric ICU, New Civil Hospital, Surat at 20th May 2023.
Saurabh, you should not reveal the name of the patient also, identity.
Okay, sir.
Okay, go ahead, Saurabh.
8-year-old female child, Nandini, was brought to emergency department via ambulance 6:30 a.m. in the morning with a chief complaint of tightening of all 4 limbs with abnormal jerky movement in all four limbs, associated with uprolling of eyeballs and associated with frothing from mouth and generalized clonic type of convulsion, which is associated with loss of consciousness and passage of urine after convulsion was present. Convulsion was started at home around 6:20 a.m. in the morning. This was relieved on injection midazolam. This convulsion lasts for 10 minutes. This condition was first time since after birth.
So, Saurabh, this is history. And for history, generally we write it what is the language of a parent or the informer.
Yes,
so here, was the parents knowing that the injection given was midazolam?
No, ma'am.
So whatever history we write,
मतलब,
always write.
relative told us कि in a private hospital, मतलब they gave an injection. After that conversion was relieved. So
Yeah,
we
so you can write
suspect
that there is
the injection
no.
was Midas.
We cannot suspect anything like that it is an injection of midazolam. Yes, if you are asked, you can always say, but while you are writing the
Okay.
history, you can always write that there was some injection which was given to relieve the abnormal movement. Another is you use
Okay.
the word convulsions. So
Okay.
conversion is also not a word which is used by parents.
Parents.
Okay, if they are parents who are very well educated or they know the medical terminology, they may know that it is convulsion. Otherwise, it is
Yes, ma'am.
abnormal movements.
Abnormal
Now we
jerking.
need to decide whether whatever the abnormal movement is there, it is seizure or not.
No. Okay.
Okay. So
Okay.
whatever history you write, always write in the language of a parent.
Okay.
Experts comment, please.
Yeah, there are 2-3 basic principles you have to obey here. One is presenting complaint, history of presenting complaint. It is all undergraduate teaching is always in patients on words. Secondly, you have to go chronological order. Here, 2-3 aspects are there. One is the timing of the seizure, 6:20 a.m. Second is a female child, male child, sex of the child. Third cause is non-consanguineous marriage. These are the important points you have to, any neurology case. When you are discussing any neurology case or speaker. So what are disease can occur only male, a seizure with only male can happen. What are diagnoses? Some other problem also, so I am saying the timing of the day, what is important? Madam, whether it's seizure or not. So the night time, early morning, it is a possibility or was a organic seizure rather than a functional seizure. A 8-year-old female, chance for the female, there may chance for functional psychosis seizure is there. But early morning, late night, maybe always a organic seizure, a real seizure rather than a psychotic problem. So timing of the day is very important. Late night, early morning, all these things, there are specific seizures there. So timing of the day also very important. Certain diseases, mainly when we are discussing diseases, it is a neurodegenerative disorder. Some of them will run only in the sex. So what are the X-linked? I know Rajat. What are the X-linked neurodegenerative disorder? I am not saying it's neurodegenerative disorder. Neurodegenerative disorder will present with neurodegeneration, seizure, cognitive impairment. But here, so before that one, so what are the diseases that will happen only in males?
So among the X-links, we have Rett syndrome, which can be X-linked dominant. Neurodegenerative Rett syndrome, X-linked dominant. Then we can have Huntington's chorea, fragile X syndrome, which usually present with CNS complaint.
So all this we can want to include complete neurodegenerative disorder. We can see that Fabry's disease, it may fatty acid metabolism disorder. Then you get uric acid metabolism, Schneehan syndrome. Then you get protein metabolism. You get OTC deficiency. So and we got certain mucopolysaccharide. You get MBS, for example, Hunter. So we should be very specific whether it is male, female, age, and also timing of the day. Everything is important here. And also, I don't know whether it is. I continue. I think so many things are missing here. You continue. Sorry.
Okay, sir. Negative history, sir.
Yeah.
No history of fever. No history of cough, cold, and breathing difficulty. No history of vomiting, headache, and blurring of vision. No history of ear discharge. No history of fall down and trauma. No history of rash, and no history of weight loss and anorexia.
Were you particular about the weight loss and anorexia?
Sir, as we suspect baby have a TB meningitis. So differential diagnosis as a weight loss and anorexia.
Any other cause? Any other cause? Hypothalamic about hypothalamic syndrome. You'll get so many endocrine features will get it. And what about, I don't know what is the other name of another Rajat we already asked, then Aradi. So fever with this seizure, what are the possibilities? No history of fever. If there is fever and history in 8-year-old child, 8-year-old child, what are the possibilities?
So fever with seizure.
8-year.
Sir, fever with seizure, it can be due to meningitis or encephalitis. It can be bacterial or viral onset. Tubercular meningitis can also present with similar complaint.
Yeah.
Brain abscess sometimes can also present with fever and convulsions.
Yeah, cerebral malaria also very good.
Cerebral malaria, yes, sir. Yes, sir. Dengue encephalitis also can present.
Yeah. Febrile seizure plus, because you won't get it. Yeah, exactly. Yeah, we are not asking very difficult question. We are syndromic approach. A child with a seizure, then different aspects. Yeah, it is not a very difficult. So how to approach child with a seizure? That is our main question here. So here he mentioned some important native such very good. Okay, then carry on.
Okay, sir.
We are going backward.
Sir, no past history of same complaint, no history of hospitalization in past, and no other significant past history, sir.
So many history, Jai Patel, I don't know whether he's student or not. So many history are missing here. So can you once again, you can see what are the other history you missed here? The one. Some history, important history missing here.
Medication history.
So when you are saying seizure, first you have to make sure it is seizure or not. What happened after seizure? Whether pre-ictal, we are not concerned with over here. Post-ictal, how many hours he slept or like that. It is tonic, clonic, myoclonic, what is it? Whether it is focal or generalized, left side, right side, focal to generalized. So all these data is very, very important. So it begin with one side, then generalized, left side, right side, any facial deviation. You mentioned about urine incontinence and tongue biting, which is not considered nowadays not significant. So whether it is focal seizure or generalized, it is a seizure itself. It may be seizure because early morning I will be already told, but it may be a seizure mimicking condition. So, Rajit, what are the seizure mimicking conditions at this stage?
Sir, seizure mimics. So one we can have syncopal episodes.
Yeah.
Then electrolyte disturbances.
That is not seizure mimics. That is a symptomatic seizure. Aradi?
Sir, conversion disorder, non-epileptic psychological disorder.
If it is a small child, what are things? What is shuddering attack?
So shuddering is similar to shivering of the body in baby.
What is a gratification disorder? Gratification, a female child, gratification disorder.
Sir, it is self-stimulatory condition in which.
So you have to roll. But first you have to see that whether it is seizure or seizure mimicking condition. Once you roll out the seizure mimicking condition, you have to go seizure. Then it is focal seizure, generalized seizure, provoked seizure, or epileptic syndrome. So here, whether focal seizure, because treatment is very important. To treat a seizure, what you want to think is that whether it is epileptic syndrome, focal seizure, or generalized seizure, or symptomatic seizure. Here, very unlikely to be symptomatic seizure. So we will go for and epileptic syndrome also. Very unlikely. What do you mean epileptic syndrome? Rajat, who else there? Sorry, but you can say what is epileptic syndrome? Just first name some epileptic syndrome.
Sir, Ohtahara syndrome.
Yeah.
Dravet syndrome, LG syndrome.
Yeah. So you got for example, infantile spasm West syndrome. So what is it? Epilepsy syndrome based on West syndrome or something like that. There will be definitely genetic etiology, different pattern of EEG pattern, different clinical pattern. Prognosis depending upon this item. For example, some of them have got very good prognosis. Absence is a very good prognosis. Whereas West syndrome and Lennox-Gastaut syndrome, you got a bad prognosis. So the specific, that is so prognostically also it is very important to know whether epileptic syndrome or not. Okay, that will keep there. Because 80-year-old child, it may be very unlikely. So we have to know whether it's a focal seizure or generalized. Why you omitted that part, Sohrab? It's not good. So you have to mention it's a focal seizure, generalized seizure, focal to generalized. How many long? Postictal palsy, postictal.
Patient have postictal urination, postictal confusion was present. So we suspect it was generalized clonic type of conversion.
Yeah. Okay.
All four limbs are involved. Up rolling of eyeballs.
Yeah. Next past history. Okay. Anyway, you are touching past history. Okay.
Sir, no family history of seizure disorder, and there is no history of Cox disease.
So actually, you have to draw a beautiful family diagram here. A PG should draw. When you are saying, I think before family history, we have to be antenatal, natal, postnatal history. That's very, very important. I don't know the presenting order. It is like that there because history of presenting complaint, past history, then antenatal, natal, postnatal history. Then you have to go like that. I think family history come after that. Anyway, you start family history. So family history, you have to be very, very careful in the sense that you have to draw a family tree. That is true. So what are the important family history here? We already mentioned about autosomal recessive, autosomal dominant, X-linked recessive. Yeah. Family history contact also very, very important.
8-year-old female child with juvenile myoclonic epilepsy.
Yeah. What else? My family history. Any neurodegenerative disorder, neurodegenerative disorder, all these things you have to take a detailed family history. Any history of abortion, first child, male child, female child. Now, what is the common seizure occurring in the family? Are they? Common seizure.
Sir, febrile seizure are commonly
50%
febrile
of seizure. It is a type of mode of autosomal dominant. So that is a commonest mode of inheritance. So, Anna, what is the incidence of febrile seizure in the family? Or how many percent will get a history of family history of febrile seizure? If there are 100 febrile seizure patients are there, how many of them will get a family history?
6%, sir.
50%.
50%. I think that is too much.
6%, 6 to 10%.
So that is a general incidence of febrile seizure in the society. In India, it is around 68%. In some other countries, Japan, it is 10 to 12%. But family history means one family, then you get 1/3, 33%, 30 to 33% history of family history. Okay. That's important family history here. Okay, here it is not, we are not considering. So can it be something else? If there is history of febrile seizure in the past, now there is a febrile seizure. What do you call it? History of febrile seizure.
GFS plus.
But
GFS plus.
That may be with the fever. If there's no fever and the neurodegeneration, history of a febrile seizure in the past, now there's no febrile seizure, but there is a seizure and neurodegeneration, what we call it?
Dravet syndrome.
Yeah, Dravet syndrome like that. I don't say, so you have to explore all possibilities. Okay. Next one. So avoid delay. You continuously present.
Okay.
Except when you asking question. Yeah.
Antenatal history. Mother is gravida to para to live birth to no abortion, no any obstetric complication were present, no history of diabetes mellitus, hypertension and UTI in mother, no history of convulsion and blurring of vision in mother during pregnancy. Iron and folic acid tablet were taken by mother 3 months during pregnancy, and 2 TT injection was taken.
So here history totally inadequate. So I am an exam teacher like that. I will say straight away. I just okay, good. I won't say like that. It is not birth history. Here it is not birth history. It is something else. So Anna, previous slide. So here so many things are missing. First of all, when you are presenting antenatal history, first trimester,
Trimester-wise.
second trimester, third trimester. So what are the neurological problem? We'll get due to some problem, first trimester, second trimester, third trimester. So the first trimester, what are important?
We suspect fever with rash.
Yeah, you have to mention fever with rash. It may not be, we know 8-year-old child may not be very unlikely. But first time you have to ask what are things. Fever with rash, then
torch infection. If mother having torch infection during the first trimester, then neurosequelae are very toxoplasmosis.
Yeah, anyway, fever with rash, whatever it is. Okay, you have to ask for that one. Then what else?
Consumption of folic acid.
Who is answering?
Very conceptual.
What other things you want to ask?
If mother is not taking folic acid and iron, we can suspect neural tube degeneration.
No, you have to either you have to ask any drug intake by mother.
Radiation and drug.
You have to radiation. Okay, you have to ask her drug intake with mother. So there are three important antenatal things you have to ask her. First is you have to ask any intra-uterine infection. Second, any drugs and radiation. Third thing is any disease of the mother, either diabetes, hypertension, SLE, whatever it is. So these things should be come here. Because it is a neurology case. In neurology case and hematology case, what are things is there? You have to ask first trimester, second trimester, third trimester. What is important in history of UTI? No.
Any subclinical infection.
The high grade fever and cytokine release, you get more chance for CP. I think everything is written in standard type, so it is written there. Even history of UTI, you have to ask. Any history of drug intake, any history of suggestive of intra-uterine infection. I am not saying that. So, Anna, what's the triad of toxoplasmosis, congenital toxoplasmosis?
Hydrocephalus.
Chorioretinitis, hydrocephalus, and intracerebral calcification.
Yeah. So, you see, once in a while, we are not because you don't get you get microcephaly or macrocephaly. But such a thing say, so first of all, you have to divide first trimester, second trimester, third trimester. Then you go for natal history. Okay, natal history. Birth history is not here. It is this family tree should come under family history. So it is after the birth. It is not the birth history. It is okay. Yeah, it is okay.
Date and time of birth 6 November 2018. Birth weight 2.9 kg. Full term.
Everything is 6th November 6 a.m. His sister also 6 a.m. Everything is 6. So you make the presentation very happy and pleasant one. Don't take it seriously. We'll go like that. It's a discussion only. Okay. Yeah. Neha, madam?
Yes, sir. And yes, in this discussion.
I don't think that I'm dominating. You ask.
No. I'm here only, sir. And you are always taking it is in a light mood. That's the best thing.
Okay. We'll carry on, madam. We'll carry on.
Yes.
From normal vaginal delivery, appropriate for gestational age. No any congenital anomaly noted. Cried immediately after birth. No history of neonatal ICU admission. Birth vaccine received on first day of life. Breastfeeding initiated in the first hour of life.
Here also so many things are missing. So Alji, can you add something here? A child with a neurological. I am not saying a child with 8-year-old child with history. I am discussing a child with a neurological problem. So what are things you are wonderfully missed? Are they?
Jaundice.
Yeah, you have to ask for jaundice. Neonatal seizure.
Feeding difficulty.
Feeding started breastfeeding. First he mentioned in cyanosis.
Activity. Conversion history, birth history of any conversion.
So all these things you have to ask because everything is independently, and also when did the child pass I had given some warning to you because you should thoroughly edit your presentation. That is why, because what is very important. Why stool and meconium? And what are the conditions you get delayed meconium and stool passage?
Hirschsprung's disease, cystic fibrosis,
common here.
Anorectal malformations,
hypothyroidism you have to look for.
Hypothyroidism.
So that's more important here. Jaundice is also hypothyroidism. So everything is important here. So when you are presenting a case, you history focus on that particular neurology case. Here you have to focus on neurology case here. So it is what needed for what we are expecting a PG student when presenting a neurology case this much at the level of a MD pediatric student. We are not a neurologist, something like that. So what we are expecting is like this. Okay. So all these things
from Ritesh, sir.
Birth history also, postnatal history also. It is not birth history. It is postnatal history. Natal and postnatal history. This is also something 50% is correct. 50% is 50% inadequate. Okay. What he written is normal, but we have to add more points. Okay.
Yes. Ritesh, sir, your comments.
No, actually, Anand Keshwan sir is like examiner many times. So I thought just he lead the discussion. I'll ask whenever needed. After whole history, I'll put few questions for.
No, you cannot. I am in the spirit. I am going like that. You can ask question.
No. It's fine. I am here always available for the students. So we'll take advantage of you today. That's why.
And all these students are from my own college. That is why. I studied in Surat only, and Anna is my student also. Okay.
Yes.
Okay, then. Yes.
Continue, Saurabh.
Continue.
Postnatal history. The patient has been exclusively on breastfeeding on demand up to 6 months. There is no history of top feeding. Complementary feeding was started after 6 months. There is no any significant history in postnatal period.
Madam, you ask something, madam? Because, Saurabh, when you are presenting a history, antenatal, natal, postnatal, that will come under diet history. Immediately after, then you after delivery, immediate outcome over, then you have to be this diet history. Then you go to immunization history, then family history, then social status like that. The order may be changed. That may be something somewhere submitted some different, but yeah, that history should be completed. So what here presenting feeding everything will be in the diet history. Postnatal history means postnatal. It is not postnatal. 6 months is not postnatal period. So it should not. That is diet history. Okay. I think postnatal history we already described. Then. Okay. Continue.
Diet history. Mixed diet and normal diet, protein or developmental history, all gross motor, fine motor.
Diet history, okay. Any dietary restriction?
And two.
Any diet, what are the neurological diseases you advise diet restriction? Or any special diet?
PK, phenylketonuria.
Yeah. So here you have to listen exclusively breastfeeding up to 6 months. After that, he started weaning. Then this is attributed. Now he's getting this much of calorie. Actually, you have to calculate it, and then you have to calculate. It may be difficult for an online class, but face-to-face class, physical class, you have to present it. That is true. Second thing is that any particular diet restriction, any special diet. Here, child with seizure. So, what any special diet will you advise?
Ketogenic diet.
Yeah, something like that. So it should. So diet history, any diet restriction, what calorie he is getting, and any special diet advice. These are 3 things should ask in diet history. This should be there in each and every diet history. So, for example, Nephrotic syndrome, there will be some diet restriction. You will have to calculate a protein calorie. Easy to remember. Then also some diet, special diet. So such things be there in neurology also, because as she mentioned, galactosemia. you should restrict milk diet. Or Wilson
Lactose
diet,
intake.
Wilson disease. It may be some neurology, so you have to careful. Thalassemia. So such things are there. So any special diet restriction, any special diet, and how much calorie protein he's getting. Okay.
Developmental history. All gross motor, fine motor, language, social development at normal age. Neck holding at 3 months, running at 18 months, scribble at 24 months. Child is studying in 3rd standard with good in study.
What about vision and hearing? That is also you have to include here. Vision and hearing. Okay. Next step.
Baby was fully vaccinated up to 5 years of according to national immunization schedule.
So what is importance of immunization in a case of neurological disease? Something Rajat. What's the importance of the immunization?
Sir, cellular component of pertussis can be a triggering factor for seizures.
And it can also cause encephalopathy.
Yeah, so there are two of the important. Some disease you can completely prevent. For example,
pneumococcal meningitis.
Some disease you can, they may be making some complication of the vaccine itself. For example,
post-diphtheric paralysis.
Rubella, rabies, and some disease like that. So all these things you have to, here it is a seizure. Okay, 8-year-old child, we are not expecting nothing like that. So it is okay. Otherwise here, so, but you have to see what are things, disease, what are vaccine. But here taken pneumococcal and other vaccine?
Yes.
Pneumococcal vaccine are taken?
No, patient haven't taken pneumococcal vaccine.
Because it is there in national immunization schedule.
And it's not included in NIP.
It is not there in your immunization schedule?
Yes.
Pneumococcal.
The child had taken pneumococcal vaccine or not? My question, because that is the commonest cause of a serious meningitis. So your child had taken pneumococcal or not?
Sir, pneumococcal vaccine is recently added in a NIP program. And
how recently? Not very recently.
2017. 2017.
Yeah. So he may not be taken it. What about Hib? So you have to check the immunization card like that. You have to check it. Is there any BCG scar there? Now you can say yes or no. I don't mind. But you have to look for BCG scar. So BCG scar present there because here one of the most important DD is tuberculosis.
Tuberculosis.
So BCG scar. So you cannot believe like that. You have to check it. So BCG scar present or not. Then you have to say pneumococcal. Some controversy is whether they are taken or not because pneumococcal vaccine is doubtful because he's 8-year-old boy. Hib whether he had taken or not. We are not expecting either varicella vaccine or meningococcal vaccine support to take in this patient. So at least national schedule you have to confirm because this child may be a pneumococcal meningitis also. So you have to think about such a line. So you have to confirm they are not taken pneumococcal vaccine, but they are taking Hib vaccine. BCG scar present. I think that may be ideal. Sir, good evening, sir. Good evening, Prajapati sir.
Yes, Dr. Anand, good evening.
Yeah.
Just now, I'm in your state, Kochi.
So here another Prajapati is presenting. Saurav Prajapati is presenting.
Yeah, I think your point was quite valid. In any CNS case, we'll have to find out that which vaccines were given. Very important.
Yeah.
Just for the sake of students to remember BCG, even HIV, pneumococcal, even suppose the patient is coming from that endemic area of Japanese encephalitis, that also we'll have to check. Because, pneumococcal, very important vaccines. Even history of, suppose some dog bite in the past or rabies vaccine, these points to be noted once you are presenting the case of the central nervous system. So I think this very important point, sir, has pointed out. Please keep in mind all the students. Thank you very much. Please go ahead.
So, Dhaval, what do you think about protectivity of BCG vaccine? Just a discussion.
Yeah.
Maybe you can discuss in favor, you can discuss it because you have important DD, whether it is a MRI, whether it's a clinical picture, will come TBM. So what is the role of BCG vaccine? We'll just, because BCG vaccine, first vaccine in the schedule is BCG. Most controversial vaccine is BCG.
BCG vaccine prevents severe form of tuberculosis.
Severe form of tuberculosis. Any other? What is the severe form of tuberculosis?
Extensive
Tubercular meningitis, miliary tuberculosis, disseminated pox, like tuberculum mono.
And my students, here 3-4 students are there. So how many TBM patients there is a absence of BCG mark? All of them are vaccinated or not? TBM, you are seeing so many cases of TBM. All of them vaccinated or not? They are all vaccinated. All of them are vaccinated. All TBM patients you are seeing, these are vaccinated. I am not going for any controversy. But so what is modified form of tuberculosis? Modified by BCG vaccination, modified the TBM. What are they? So you may get a serous meningitis, that is Lingolen's meningitis. You may get tuberculoma, and you may get localized tuberculosis. So it will modify. It is some form of modification. Otherwise, it's not much protective. It is personal opinion. So you can see BCGs are almost all patients, but they may have TBM also. Okay, next one. So when you are discussing diet history, development history, immunization history, it should be complete in that sense, focusing on neurological. If you are presenting a respiratory disease, then the immunization history also very important. But then you have to focus something else. In that way, if you are presenting a neurology case, so you have to focus in that way. If you are presenting a respiratory case, you have to present it. If you are presenting a GAT disease, then you have to present it way. So, Rajat, what are the GAT protective vaccine? GAT disease protective vaccine. Just for time pass.
Rotavirus.
Why you start from
rotaviral vaccine?
You start from one end. Start hepatitis B,
hepatitis
OPV.
Hepatitis.
So going in order. That is second rule. So going in order. So hepatitis B is there, hepatitis A is there, your rotavirus vaccine is there. In that order, yes, and it will be very simple and easy. Okay. Then next.
So socioeconomical history belong to lower middle socioeconomical class according to modified Kuku-Swami classification. Nuclear family, 4 members. Father works in textile factory. Education of father is up to test standard, and total family income 10,000 per month.
Okay, but since we are dealing with a case of conversion, suspect TBM, any overcrowding, any ventilation, such things you can mention here. So you have to modify. If it is asthma, something different. If it is diarrhea, something different. If it is a PM, something different. Here in neurology case, we have nothing to add, but at least in our mind, you can keep very good later. There is overcrowding or something like that you can mention. Okay. Okay, next one.
Clinical history summary. This is the case of 8-year-old female child named Nandini, born first in order out of non-consensuous marriage, who is resident of Kalika Nagar, Pandesra, Surat, and belonging to lower middle socio-economical class as per modified Kuku-Swami classification. Patient was asymptomatic before 6 p.m. to 6 a.m. 20 May 2023. Patient came to New Civil Hospital Department with emergency department with chief complaint of tightening of all 4 limbs, frothing from mouth, and associated with loss of consciousness with
it is not a summary, it is the entire history. He need not mention about the medical college or as a Pandesra, everything. He need not mention. The 8-year female child with acutely present with the casualty, with a severe seizure in the morning, and he responded to some drugs. Everything it is a not summary. So the arts and science of summarizing a history is very important. I may be concentrating my mobile. I am not attending the entire case presentation. Then I ask to summary. So it is not summary. That is also an art from your side. How to summarize various no history of contact with TB.
Because I may not be familiar.
And non-consanguineous, everything will come here. So many things are unneeded things are there that you can avoid in a summary. Baldev sir?
Hello.
Yes, Dr. Anand, I am joining within 2 minutes because it is already laptop. I am switching on the laptop.
Yeah, sure, sir. Ritesh, sir, your comments.
So basically, Dr. Anand Keshwan has beautifully described, asked about various aspects of different histories like birth history, family history, importance in CNS case. Now, coming to this case, Saurabh. So, 6 a.m., child is presented with some tightening of limbs. So, first clinical question we have to answer here is whether it is seizure or something else. So, what is your take based on all your facts available? Is this seizure or something else?
Sir, it is seizure because it's associated with loss of consciousness and jerky movement of all four limbs.
It can happen in syncope also. Syncope can also have jerky movement and unconsciousness. Why is it not syncope? Syncope can also have jerky movement and loss of consciousness. Will you
with uprolling of eyeballs, and clothing from mouth was present, and post-ictal confusion
These
and
all things can happen. What is
urination.
the most important?
Post-ictal urination was.
Urination can also happen in syncope. This is the point. Beginning. You are getting my question. So what is the most important point? Why it is not syncope? Syncope has a situation where
it was lasting for
change of posture or anything.
Sir, it was last for 10 minutes and it is only relieved by anti-seizure medication.
Any other most important point? Situation. What is the situation here? The starting point.
Sir, patient
sudden onset of
patient have a jerk followed by loss of consciousness in syncope.
Moving here and there with specific points. What I'm asking, your syncope starts in which situation, and this condition is starting in which situation? Situation is most important. Here it is from sleep. Here it is from sleep, and patient is lying down in the bed 6 a.m. in the morning. So syncopes usually start in which situation?
Long-standing standing exercise.
Postural change, sudden change of posture.
So syncops usually start in upright posture, while this is while sleeping, so unlikely to be syncope. First point.
Okay,
second point, there is no any provocation like prolonged standing or urination or whatever. So it is very clear from the beginning only that it is not syncope. I'm just asking for sake of completion. Okay. Any other non-epileptic things can come with jerking and unconsciousness? Any other non-epileptic event? Any sleep disorder possible? Suppose I am telling that this is parasomnia and this is some kind of sleep disorder where patient is moving his limbs in the sleep. So I'm going to differentiate sleep disorder from seizure clinically.
Sleep disorder can be stopped by holding a child, while seizure can't.
Okay. Any other point?
Sleep disorder will develop gradually. Seizure onset will be acute and sudden.
Both can be acute, but usually majority of parasomnia happens in which kind of sleep, if you are aware? Non-REM. Majority of parasomnia are from non-REM. And early morning, what is the dominant sleep? Early morning?
REM.
So most of the sleep disorders are in early sleep or middle of sleep. They are less likely to be in the later part of sleep. Okay. So here it's less likely to be a sleep disorder, at least less likely to be a parasomnia. Non-REM disorders are less likely in the early morning. That is important point. Any other point for differentiating between sleep disorder and seizure? Because early morning, nobody has seen the onset. Okay, mother and father maybe they are also waken up by jerking. So nobody has seen the onset. So there are lots of things we have to think about. So less likely to be sleep disorder, less likely to be syncope. Any other thing? Could it be psychogenic?
No, his child was sleeping, so it's less likely.
Psychogenic, it is out of proportion movement.
Ritesh sir, you are muted.
Second, sorry.
Yes.
So first thing we are sure here that this is seizure. It is not syncope. It is not psychogenic. It is not sleep disorder. From history, from your given facts, this seems to be seizure. Now my second question is, if it is seizure, what is the type of seizure here?
Sir, patient having a all four limb involvement, generalized tonic type of convulsion.
Okay.
Yes, a prolling of eyeballs, clothing from mouth. So it all suggests generalized tonic type of convulsion.
So now all residents present here, please be careful while classifying your seizure. So seizure classification is based on onset, and it is not based on what is happening during seizures. Okay. So latest seizure classification, if you see, it is focal onset seizure, generalized onset seizures, and unidentified onset seizures. Okay. So here, what is the seizure type?
Generalized.
Generalized tonic-clonic is when?
On onset.
The child. No, nobody has seen the onset here. It is during seizure, parents have noticed that he is moving all four limbs. Okay. So we don't know the onset here. Nobody has witnessed the onset. Child is sleeping, parents may be sleeping or in some other room. So generalized tonic-clonic movements, whatever you are describing, it is a part of seizure. It is during the seizure. Okay. And your frothing and uprolling, these all are non-specific. They cannot tell you whether it is focal or generalized. So be clear. Now you are doing PG. Okay. So don't go non-specific. Don't use non-specific words. So whatever word you use to describe your seizure has to have some meaning. So here it is generalized tonic-clonic movement, which is part of your seizure. Okay, it is good. So we are sure that all four limbs are involved at some point in the seizure. During seizure, all brain is involved. That we are knowing from your facts. But onset, so here your classification would be unknown onset.
Okay.
Okay, because it may have secondarily generalized after focal onset. It may be generalized from the beginning, but you are not sure. If you label as a generalized, your thought process will be different. Okay, so when you are not sure clinically, just put a broader view that this is unknown onset seizure from sleep. Okay, from your given facts, whatever I am getting, some 8-year-old girl is getting her first seizure in life 6 a.m. in the morning. That is the clue from your history. So here the classification would be unknown onset because nobody has witnessed the onset. Okay, now my third question. So any seizure you see in casualty, as a resident, you must be seeing patients in casualty with seizures. You are giving midazolam, lorazepam, whatever diazepam to control the seizure. Now, third question is, this is what must be the most probable etiology according to your history? We have not gone to examination yet. So it is just based on history. This is epileptic event. This is unknown onset seizure. And now we are thinking about etiology from your history. What do you think? The answer that whenever you see first thought, what is the first differential in your mind? Anand,
Any CNS infection, sir?
First thing you think,
meningitis.
Why you are going directly to meningitis? Here is a 6-year-old girl. Just be with this case. I am not asking any theory. Okay, this case. So this case,
Sir, female child, so we can suspect juvenile myoclonic epilepsy.
So directly don't go for syndromes. So it could be genetic. According to you, it could be some genetic epilepsy. But that is the second part of your thought process. First part is what? Whether this seizure is acute symptomatic or is part of some underlying chronic process. That is the first differentiation, because your entire management will be different in these two conditions. Okay. So first differentiation, any seizure patient, whether it is an acute symptomatic seizure or it is a part of chronic underlying process. So here from your history, whether you are sure that this is
learn how to allow the access to your machine. And you can click on now zoom to access your camera and microphone.
Hello? Yes, sir.
So whether this is acute symptomatic seizure, acute symptomatic means I just tell you
after investigation we can say.
I'm not telling about investigation and history. So from history, your differentiation should be very broad. Okay. So first seizure, you are seeing 6 AM, ungmathi uthyo hai tu, kaatni duty ma. So anything can be there. He may develop fever later on. He may develop vomiting later on. He may develop encephalopathy. He may be on ventilator after 2-3 hours. We never know. So we just have one history of seizure at 6 AM. So just keep in mind all your acute symptomatic causes first, which are life-threatening. Okay, all your meningitis, all your encephalitis, all your electrolyte disturbances, all your traumas, all your strokes, anything can present with first seizure. Okay, so till you get the other histories, as Dr. Anand Keshavan has told you, this is a very inadequate history actually to diagnose. Okay, so right now, seizure, epileptic, unknown onset, these three things are sure from your history. Rest all is open. So thousands of differential of seizure can be possible in this case. But first point is whether acute, you are dealing with acute situation, you are dealing with chronic. So that will be clarified on follow-up. Like same day, if you examine the child at 8 AM, 10 AM, 12 noon, evening, suppose evening child is playing in the ward, running around, he is having no deficit. Then you are dealing with some chronic condition which is presenting with first seizure. Okay, you are getting my point.
Yes, sir.
Okay, so I think
Dr. Anand, yeah.
Am I audible?
Yeah, we can go for further examination. 1 hour over.
Okay, thank you.
Examination fine.
So I think next half an hour we'll discuss examination and then half an hour investigations. Thank you.
General examination. The patient has been examined by me with full exposure from head to toe with consent of parent. Patient was active in conversion at a time of admission and relieved by injection midazolam and regained consciousness after 1 hour. Temperature 36.7 degrees Celsius, heart rate 98 per minute, RR respiratory rate 20 per minute, SpO2 99% at room temperature. BP was 110 by 70 mmHg. No signs of renal.
So here there are so many things. Previous slide. It's a very important slide. Previous. So here what you miss is that first of all you have to mention. Okay, at the time of emergency you seen the patient, but now what is the condition of patient now? There are so many things that are there. If the patient is in an unconscious stage, now also unconscious, it may some encephalitic form. Previously it was in a sedated stage. Now child is active. It is something less serious. And you have to mention any particular posture, decorticate, decerebrate, how child is kept, and how any particular. And also very important, why you have mentioned about heart rate. You are not getting any pulse, you are getting heart rate. A PG student should not. In a newborn, it is okay. Heart rate is because here child with the seizure, you are saying that a patient was in a state of convulsion. You have to mention the pulse.
Okay.
Rate, rhythm, volume, where is it is? Because our DD is syncopial attack. We got a heart block. We got so many arrhythmias. So there's no meaning of mentioning a PG student heart rate here. You have to have pulse rate only. The volume of the pulse, rate, rhythm, volume, guide, everything, brachiophemia, everything you have to mention, no doubt. And also, next respiratory rate, which is regular, irregular, abnormal-thoracic, any particular pattern. So all these are very, very crucial. Never tell heart rate in this case. You know, not any pediatric case should not tell heart rate. You are just you examine pulse or heart rate. Frankly, I'm asking you, sorry, you examine pulse or heart rate. Which one you examined? You auscultate and then you are saying, or you palpate pulse. Pulse. So it's important. You are conversion child. You have to see whether pulse is low volume, high volume, regular, irregular. It is very, very important. Also, temperature important. The respiratory rate is so important. So you have to mention all these things. And after BP, we are seeing no signs of rise in the ICT here. After BP, you are seeing no signs of rise in ICT here. How can you say like that?
No hypertension, no bradycardia, no irregular type of.
That is mentioned. What is Cushing triad? What is Cushing triad?
Hypertension, bradycardia, irregular type of breathing.
Yeah, you mentioned the pulse rate, you mentioned the respiratory rate. There's no, you need not mention any no signs of rise ICT here.
Okay.
I think the heart rate should not. Well, I don't know whether practice, what is their practice. You used to say pulse rate only.
Okay.
Yeah, it is important because heart rhythm, bradyarrhythmia, tachyarrhythmia, it may lead to a seizure-like condition. Okay.
May I speak? Am I audible, Dr. Anand?
Yeah.
Are you getting the echo?
Yes.
Are you getting my echoes?
Yes, sir. Echo.
Okay, I think there is some problem. Anyway,
if you have two connected devices. That's why maybe there is echo.
One is
maybe connected to device. Yeah.
So please try to speak again.
Yeah, next slide. By Saras getting ready, we'll go for next slide.
Baldev sir, please try to speak again.
Yeah.
Yes, sir. Still there is echo. Yes. So you need to unmute.
Sorry.
Yeah.
Yes, sir. Now you are audible enough.
Audible.
Yeah.
Okay.
Yeah.
Sorry the interruption from my side. I'm extremely sorry. But I think what Anand was insisting is very, very important point. And I think in the exam, many a time students unnecessarily invite the trouble. Because absolutely what sir said, in a 7-8 years old child, if you mention the heart rate, any exam, that means have you not taken the pulse rate? That will be the first question. So very, very important. Second, once you are mentioning the vital, many things are clear. That vitals point of view, perfusion is good, respiration is normal, and there is no any tachycardia. So it conveys many things. There is no necessity to mention separately that no signs of raised intracranial pressure. By mentioning such things, we are inviting the trouble in the exam. So I think you can do the mistakes over here. It's a good thing because if you do the mistakes, it can get corrected. But at least in the exam, don't do like this. And very important was sir mentioned in the general examination, always mention the first point. I think you are in such patients, sorry, I have not heard the initial part, but you should mention on which day of the admission you are examining the patient, because that also makes a difference. On the day of admission, there may be the different picture. After 2-3 days or few days of the treatment, the picture presentation of the patient will be quite different. So you can mention that the patient was examined after 4 or 5 days of admission. That means some treatment or something is already given. And that status you are mentioning. And here somebody may ask that what was the presentation on admission? So I think that point should be clarified. Everything
when you are examining, and from the postgraduate, all the things are expected distinctly. I think you should mention so that there should not be any confusion, and your I will say messages should be clear. At the end, when you are deriving this, at least some conclusion, it should be very clear. So I think, okay, well done. But sir has pointed out very appropriately. So please keep in mind. Go ahead, please.
Anthropometry. Patient was undernourished. Weight is 25 kg. Height 122 centimeter. And BMI was 16.6 kg per meter square. General examination.
Don't think that I am interfering in each and every point. I'm really sorry. Previous slide.
General examination.
Anthropometry.
No, sir, previous slide.
Okay.
So it is undernourished child, 8-year-old child, 25 kg. So this is what you have to interpret the findings. 25 kg is adequate, inadequate. What percentage? Height.
BMI,
malnutrition, chronic malnutrition, what it is. More than BMI, we have to see what is the upper segment, lower segment ratio. Because whether what is his height percentage? What is his weight percentage? Because it's a chronic disease or acute disease. You mentioned a child is otherwise normal, certain acute seizure. If it's a TBM, there will be some malnutrition, something like that. So each and every point you are taking that spirit. Then only we can go like that. Here you have to grade the man if it's there any height shortage or something like that. You have to grade like that. BMI is not important here.
I think my question to the presenter: have you the growth charts? Dr. Saurabh, I think presenting. Am I right?
Yes, sir.
Dr. Saurabh, have you shown over the growth chart over here?
Sir, I don't have a growth chart in my laptop.
Yeah, so what another point, I think the MD examination, not MD examination, every practicing pediatrician, every patient even, apparently looking just upper respiratory, without growth chart, we cannot examine the patient. And in the examination, growth chart is very important, whatever I will say case it is, even long case or short case.
Okay.
And that's why what sir has asked very important. On the growth chart, you will have to put it. And then show even the exact interpretation that what is the nutritional status of the child.
Yes.
And that should be plotted appropriately on the growth chart. Very, very important. So please.
Okay.
Dr. Anand, should we go ahead?
Yes, sir. Yes, sir.
Yeah, please.
General examination. No pallor, icterus, cyanosis, edema, and lymphadenopathy.
Yes, sorry, but
no
why
evidence
like that? Because pallor, I agree. That's cyanosis, edema, then you come lymphadenopathy, then clubbing, then field edema. You go in order. You read the patient. From head to foot. Here you got a pallor, first agree. Icterus, eye, cyanosis, tongue. Then you have the lymphadenopathy, neck. Then go for the clubbing. Then you go for edema. It's a disorder way. A particular fashion, particular order you have to follow. Then you need not remember anything. So edema, then lymphadenopathy. Where is the lymphadenopathy after edema? Okay.
No evidence of visible opacity in eye, dysmorphic face, wide palpable space, and absent eyebrow. No nasal discharge or ear discharge. Genitals are normal. Back and spine are normal. No grunting and adventitious sound.
Here also, I am not very happy in that way, because we are going in a head-to-foot examination child with a seizure. So we already mentioned there is chance for meningitis, encephalitis, neurodegenerative neurometabolic disorder, and so many things mentioned. So you have to focus on all these findings here. You not mention about any neurocutaneous marker here. You not mention about so many other things here. From hair onwards, you have started. No microcephaly, no macrocephaly. Head segments you not mentioned there. You not mention at all microcephaly, macrocephaly there. That is very, very important here. And here again, any head color. What is the importance of examination of a hair? In the case of seizure.
Mankey kinkies is order.
Biotinate deficiency. You may get kinky hair disease. So many things are there. So many things are there. Everything is written there. Microcephaly, then nai. What are things you look for in nai?
I think, Dr. Saurabh, can you say that common condition which even the hair changes and neurological manifestation? Go with the common condition. Don't go for the kinky hair and uncommon. I think that should be kept at last.
Yes, sir.
Can you name some condition where the hair changes with a very specific and child presents with the neurological situation, neurological condition? And most common, even I will say. Along with that, there may be the anemia and other problems also. Now, I think you should be able to answer. Dr. Aarti?
Sir, severe acute malnutrition, flat sign will be there. Child may present with conversion due to metabolic abnormality or...
Aarti, my question is very specific. The patient has prominent some changes of hairs. Child is anemic. And child presents with some neurological manifestations. What is the trial?
Vitamin B12 deficiency.
Infantile tremor syndrome.
Infantile tremor syndrome, B12 deficiency.
Right. And you know, it's a nutritional condition, it's common. So I think these are the common conditions which you can keep in mind. Of course, with malnutrition, even TBM, that can also be there. Other situations, yes. But I think you should take what I think Dr. Anand is pointing out every step, very, very important, sir, is pointing out for the exam. Your presentation, MBBS student, upper, lower, here, there, and mention something, examiner will be happy, but not for the postgraduate. Your presentation or narration should be methodological. It should be reflected that exactly you have some ideas. So it's a, I will say, haphazard way presentation can occur. But that is not right. Here, I think he has mentioned wide palpebral fissure. What was their idea? Absent eyebrows. Aarti, in which condition there may be the absent eyebrows? Because, you know, you are inviting the trouble. If you mention, examiner will ask. Then in which condition, and is it common, I will say, in your practice? Suppose even I will ask a direct question. You have completed a 3 years residency. What is the absent eyebrows? What was the reason in your patient? Able to recollect, Dr. Aarti? Have you seen any patient with the absent eyebrows?
No, sir. No, sir. No, sir.
So that's what I'm telling you. Don't invite the trouble unless an examiner asks. But suppose by somebody asks, in which condition there may be the absent eyebrows?
Leprosy.
Yes.
Leprosy.
Saurabh?
Leprosy.
Leprosy, yes. Any other condition? Any endocrinal?
Hypothyroid. Myxedema. Hypothyroid.
Any other rare condition which presents with a fever? You don't have the answer. And then maybe the totally absent eyebrows, even hairs, scalp hairs, and some nail changes. Ectodermal dysplasia. So the point is, I think here you should try to mention the relevant points, and there should be the chronology. And chronology should search that your thought process should be reflected in your narration. I think that's a point which sir is pointing out several places, and I think very, very important. So please keep in mind, mistakes can occur, there is no problem, but it should not occur. I'll say in way to the grunting and adventitious sounds are related here in the general examination. Why are you expecting grunting in this case?
Viral.
Nasal discharge, gentle is okay, back and spine, no grunting, it is not here. It totally misplaced.
You know,
its own place. It is not come out the general examination.
Yeah.
So, here we got a child with this seizure. You not mention about a neurocutaneous syndrome.
Yeah, that's the point. On the contrary,
we are suspecting TBM. What is a mark of a TBM? Sigma or TBM. You got any skin changes, something like that? What are skin changes in the TB, tuberculosis? Derma. There's so many things are there. Lupus vulgaris. There's so many things are there. So all these things you have to keep in mind. Okay. Then visible opacity in the eye, dysmorphism. You cannot go like that simply. It's very important. So I'm asking Aridi, what are the just by simple eye examination, what are the findings we'll get in a case of seizure? What is the importance of looking at the eye in a case of seizure?
Sir, to look for a papilloedema optical examination.
No, before papilloma, you start from front.
Sir, okay. Field point pupil, if size of pupil will help if irregular, in unequal size of pupil.
Even you can go for subconjunctival hemorrhage. You can look for the features of the vitamin deficiency. Somebody mentioned some vitamin here. And you can see the palpable fissures, the hair, everything, eyebrows, everything. So front to backward you have to go. Then you go to lens there. What's important is the lens? Lens dislocation, what type of opacity, what type of cataract it is, what type of dislocation is there. If dislocation, lens opacity, then you cannot go further. So what about the backward examination? What are we getting here? So eye is a very, very important examination point. What about after lens? What to look for? After lens, what to look for backward?
Retinal examination for any hemorrhages or
disc changes.
retinal.
No, then you go to optic atrophy. Papilledema. Then cherry red spot. Then chorioretinitis. Then abnormal pigmentation, NCA, neurolipofuscinosis. There's so many long list of conditions there. So my question to Aridi, what are different types of cataract you will get a different condition, neurological condition? What will you get in Garettismia? What will you get in Wilson disease? What will you get in personality syndrome? So
the all drop cataract in dialectos.
Now our ideas that stimulate you. We cannot also say completely, but you have to constantly
Christmas tree.
Which so Sarah's mentioned neurocutaneous syndrome. Which condition you want to get any cutaneous manifestation? Which neurocutaneous syndrome you want to get any neurocutaneous syndrome?
So
such a rare condition, once in a while, examiner may be very pleased to ask you. So, what is the condition?
Sturge-Weber syndrome.
State people get some cutaneous syndrome. No? You may get it without it also. That is true. You may get it totally absent. This one you will get it. Or one with Pilhel disease. It is like that something. So you have to think like that. Then any stigmata of any other disease. You have to go in that way. Any skin condition. Because there are so many conditions. Skin condition, Fabry's disease, some other ichthyosis, for example, even yes. So you get a vitamin deficiency, neurodegenerative disorder, neurocutaneous syndrome, then you get a metabolic disorder, all are such diseases. I agree, it is an 8-year-old child, all these things are very, very unlikely. A child at normal development up to 80 years, all these things are very unlikely, but you have to look for all these things. Okay, next. So you should not sell here genitals, spine, back, grunting, attention. You should not become here. This respiratory system. It is something else. So you need not mention here general examination. Okay.
I think for the students, please remember what sir wants to convey. That in general examination, first it should be come with the general vitals and very specific some nutritional deficiencies also. Later on, very specifically, your system concern or your, whatever the condition you are suspecting, check the very specific whether any point is supporting, whether anything is absent which is excluding some nearby differentials. So keeping in mind related conditions, you may find out the points on the general examination and that you will mention. Otherwise, you know, in standard textbook, everything is given. But in the standard textbook, it is given for generally. From that, candidate or the clinician should find out that what are the points related to your system, your condition, or possibility of your clinical. So accordingly, you should go for this point. As sir said very rightly, suppose here it's a CNS case, probably are suspecting some meningitis. And in that case, very specifically, you will check it that whether the BCG mark is there, whether the lymphadenopathy is there, what is the nutritional status of the patient, what are any neurocutaneous markers, or any point in short related to this. Even in eye also, sir said very important. Suppose if you are suspecting some extrapyramidal system manifestations has come, and if you get the cataract, very specifically, suppose sunflower-like cataract or KFP, that becomes very prominent feature for your diagnosis of Wilson. So the point is, as a clinician, try to find out very important markers. And accordingly, you should mention whether they are present or absent, so that it helps you to consider your possibilities very strongly at the end. You know, we are preparing the background for our thought process. And that's why related things should be taken. Okay. Should we go further, Dr. Anand?
Yeah, here you cannot diagnose with the clinical diagnosis alone. But what important is a discussion. Here, discussion is only important. You cannot diagnose what you mentioned in the beginning. You are diagnosed here diet. Anyway, you cannot diagnose 100%. You cannot diagnose this case with your bedside history, clinical examination. You want initiation. But how will you reach the way which, that is why I told first sentence, don't get biased. Because diagnosis is not important. In a clinical case, bedside, we are using the arts and science of bedside clinical examination. Even it is not bedside here now, but old people like myself and Pradhavji sir, in our time we learn like that only. So you have to go like that only. Okay, next one. Okay.
Systemic examination. I will proceed the examination of central nervous system based upon the general examination pending. In a admission, post-ictal phase, patient was under sedation after injection of midazolam. Loss of consciousness was present. Patient is not oriented to time, place, and person. Cranial nerve examination cannot be performed. Tone, hypertonia in forelimb increase the resistance to passive movement and decrease the range of passive movements. Deep tendon reflex grade +2 in present in all four limbs. Plantar reflex shows bilateral extensor response, and pupils were bilaterally equal to reactive to light, and sensory examination cannot be performed in the child.
Sir, you continue because I'm totally unhappy.
Yeah, again, what sir has mentioned,
so
absolutely.
People, students may get even Nehal madam will get.
No. I think students should take in a proper
you are
perspective.
examining patient after stabilizing the patient. Should never say cranial cannot be examined. It is not good. You can put a torch and you can get some light reflex. At least for minimum. So you should not never tell because you are examining, you sedated the child, then after that you are examining the child. We already told like that. Okay, you casually examined, but now for presentation, you are examining the child in the bedside. So it is never like that. So what we are seeing today is our presentation findings. And here you are saying that, so you have to go higher functions. What is higher functions? Not mentioned. Then speech language, because after how many days you are examining the patient? Casualty, patient coming to casualty, and after how many days yesterday the patient admitted on 6th.
Time of admission, sir.
6th. Now it is 23rd. What is your findings yesterday? We are not dealing with the findings on 6th. So what is your findings today? Yesterday. So how can you say that the patient is under control of midazolam like that? You are examining patient yesterday. And there is no
Saurabh.
And
yeah.
okay.
So Saurabh.
After gaining consciousness, okay. After gaining consciousness.
Okay, so Saurabh, you have the two types of examination. One is at the time when the patient presented, and after that when you took all the history and the consciousness regained.
Okay,
you have two types?
Yes, ma'am. The second one is after gaining a consciousness, and first one is before post.
No, there is one thing is there. First of all, if you are not examining, you are not in the casualty. How will you explain this case? You are an examination student. You are first time this patient is in the bed ward. How can you say that? So that is, you can just mention something there in the casualty. You cannot go everything, but you cannot present said two things. Patient is unconscious in the casualty. 1 week back. Now yesterday, patient is like that. That only. You cannot make a two type of presentation. Broadly, you can say something about it at the time of admission. If you are not there, something heard like that. Here you heard seeing the patient in the case, that I agree. But for examination, it's not like that. And also, back. Here also, you are saying that people have a bilateral equivalent reactive light. That you have to come in. Where is the GCS, Glasgow Coma scale? When you are seeing what is the condition of the patient? Because you are seeing the patient in the emergency room, okay. Then you have to mention the level of consciousness and things. But I don't want that part. After examination, yesterday's findings I want. Yesterday's finding. Okay, next slide. Next slide.
After gaining consciousness, patient was alert and oriented to time, place, and person. Tone normal in 4 limbs, deep tender reflex, grade +2 in all 4 limbs, power normal 5/5 in all 4 limbs, pupil bilateral reactive to light, equal in size, cranial nerve examination was normal, sensory examination was normal, no any abnormal finding in cerebellar examination. No any.
What is the order of presentation in a neurological system?
Sorry.
But you are totally disobeyed the mode of presentation. So what is the order of presentation? Rajat, how will you present a neurology case?
So in the examination, first we go with the higher mental function.
Yeah, higher function.
So in higher mental, it is appearance.
Okay, next one.
Cranial nerve examination.
Yeah, that is very utmost important here. In the case of seizure, we are suspecting TBM, some other form. Cranial examination is very important. That you cannot say that the cranial is normal. But order is something different. And you have to mention first cranial, second cranial, third, fourth, 9th, 10th, and what is it? Because it is a brainstem localizing sign. All this is, so if it is meeting normal, I agree. But first cranial, this one, second, last one, 3, 4, 6, this one. And the 5th, 7th, 9th, 8th. You have to mention like that. You can okay, after cranial, what will come? After
the motor system exam.
Yeah, motor system. Motor system, how will you proceed?
So motor we divide into 2, upper limb, lower limb, and right and left side. And we mention regarding the nutritional status of the limbs.
Yeah.
The tone.
Yeah.
Tone, power, and the reflexes.
Yeah, bulk, tone, power. The reflex, superficial reflex, deep tender reflex, sensory system, science of meningeal cerebellar science, skull and spine, everything like that. So that order didn't come here. That is why I had given warning you have to thoroughly edit your presentation. Was Nehal madam, I think I am right.
Yes, sir. Yes, sir. Even when we were the PGs, we were following the same order, and the order has not changed in these many years. It is the same. Higher functional cranial nerves. Yes, sir.
I think very important for the postgraduates, to all the postgraduates, please keep in mind that for the central nervous system also, even I tell my students, if you go at midnight, 2 o'clock, then also I will say your methodology of examination should be complete. And when you are describing, probably you may not go that higher function, but your order sequence should be that only. And very, very important, higher functions in cranial nerves also suppose normal, but if the examiner is not interested, he will say, okay, but you should start the description for all the cranial nerves. That what you try to check. Suppose 3rd, 4th, 6th, at least you can say that movements of eyeball in all the directions are normal. Okay, I think that's sufficient to say that the third, or for third hour, at least you can say that no even the ptosis, no dilatation of pupil. Similarly, you can say that the asymmetricity of the face is not observed. Nasolabial fold is normal. Angles of mouth are normal and no feature suggesting seventh nerve palsy. Accordingly, there are points for every nerve, and that you should remember, even normal that you should describe. Motor question comes, I think 5 points you have to remember motor system. This is very important, even points to the UG student. Muscle tone, muscle power, muscle nutrition, coordination, involuntary movements. These 5 points for the motor system has to come. For reflexes also, when you are describing superficial and deep. Superficial also start very methodologically, as Dr. Anand is saying, from the very top, corneal, conjunctival, right? Go for the gag reflex, abdominal, cremasteric, plantar. I think superficial. Deep also. So the point is method, and then the sensory system also you may not go, but at least you should know somebody is asking that cortical and peripheral. Cortical sensory points, you should know that stereognosis and a 2-point discrimination and something. The peripheral, even the nervous sensations, you should know that touch, pain, temperature, that means lateral spinothalamic tract you are examining. Then the proprioception and the joint position, something that means posterior column you are examining. With that, you should go that no signs of cerebral signs, no signs of meningeal irritation, skull spine normal, gait, suppose if you have examined okay, otherwise you could not examine the gait. But the point is, I think these orders should be in that way only. Very rightly you are mentioning plantar and then you go for this pupil examination. I think that order is not right. So point is, keep in mind that when you are describing, of course, when you are examining, you can go according to your convenience and patient's convenience. But after gathering the information, when you are putting together, when you are presenting, that order should be kept constantly, I think almost in all the systems. So anyway.
Hello.
Yes, yes.
Dr. Ritesh. So basically,
yes, Dr. Ritesh, please.
In the era of artificial intelligence, we all know about algorithms. So in our mind, there are lots of algorithms happening due to repeated history taking. So always follow the order. Without following the order, your AI will go wrong and you will do wrong diagnosis. So it is my personal experience. Whenever you jump some point, whenever you miss the discipline of examining in order, you will always have a mistake in a diagnosis in few cases. So I think that order is absolutely important. You should never do mistake. At 2 p.m. in the night also, as Dr. Baldev Gajapati said, you examine in whatever way comfortable. But when you put together in your case paper or your like such presentation, always go in order. Without order, our thought process will go haywire. So we'll never reach to a conclusion because we are wired to think in methodical way. All our teaching is absolutely, in CNS, it is very, very important. Other system also, I agree. But in CNS, without order, you will miss. So higher function, cranial nerves, motor system, sensory system, reflexes, then your cerebellar signs, and skull and spine. And in those also, there are orders.
Yeah.
That may be for super specialty, but for at least you PGs, these 6 things should be in order. Suppose in motor system also, there should be order, ideally. But at least in these 6 major headings, you should never be wrong. Otherwise, if some examiner can fail you also on the basis of this only. So never go wrong in your order of presentation. Whether it is relevant or not is a separate thing. If it is not relevant, your examiner will tell, just skip it. If it is not relevant, but your order should be perfect. No mistakes. So no, next time onwards, all residents present here in CNS, order is must. Otherwise, your diagnosis will be wrong.
The only thing is that when examiner can ask due to lack of time one question, what are the positive findings in your examination? That is for other system, not main system, right? Here you have to present the entire nerve system. In CVS, what is your any positive findings? Especially any positive findings? And in GAD, any positive findings? You can just skip like that. If examiner is asking like that, otherwise you have to present that system also entire. If examiner is asking what positive findings in other system, no, okay, just leave it. But you are presenting a nervous system case, you should not skip like that. That is a rule.
But at the same time, keep in mind that even in a CNS case, examination of CVS is important. Don't take it as granted that it is normal. By chance, suppose in a case of CV stroke, if you get that there is some cyanotic heart disease or something, you know that the point is, at least other systems while presentation, if they are normal, you can say that I checked other systems, if they are totally normal, even no any point related to the CNS system. If you make the point is clear. But as Dr. Anand said, absolutely that concerned system should be more in details, methodologically, in order, in sequence. And even when you are describing positive findings, there should be very clear picture in the mind of the person, I will say, who is listening, that what you want to convey, right? So it should be very, very clear. Anyway, these are the, I will say, clinical case discussion. The PG clinics are meant for this purpose. So do the mistakes, do the multiple times mistakes, let even teachers rectify and correct. The only thing that it should not be repeated every time, right? I think this time was the presentation by Saurabh. Next time, I think Aarti should come with a better presentation. And I think at the end of exam, Dr. Anand should say that now you are prepared for the exam. I think ultimately that message should come. And I think that's the whole exercise. For this purpose, all of us are doing. All the teachers are always, we are also trained that these mistakes are going to be there. We are here to correct it, and everybody has done. In the past, probably our presentation also may be more or less similar, probably. So nothing is to worry. But at the very important point, then note all the things. And whenever we are presenting, our, I will say, performance should be far better than what at present it is there. Okay, but I think it's all right. Dr. Anand, you can take it further.
Should be expert. What to be your clinical findings in cranial examination, motor system examination, reflux in the case of TBM, in the case of postmeningeal sequelae, in the case of neurodegenerative disorder, in the case of, because that is our idea. For example, fundus, second now, what is the importance of examination here? What you are expecting here in the muscle strength and this motor system examination. So you have to prepare in such a way that what is your findings here? What you find here in 9th and 10th examination? What is looking for you? And what is common scan involved? What is root value of traumatic reflex? So all these questions come in between.
Yeah.
So you have to prepare. I am saying all the students with the permission of Prajapati sir. So you have to go in such a way that cranials, everything to be. You should wait for some question from our side because it is like that only. The motor system, everything like that. So you can answer very easily. So prepare all these things by reading a standard textbook and clinical examination book. Though it will be, you'll be expert next time. We are guiding like that. Okay. Okay, sir.
On the contrary, if you are well prepared in the exam, even you can lead to the examiner. You can present in such a way that examiner would like to ask that question. And suppose if you are prepared, you should do it. But you know, for that reason, we should be well prepared. So I think that's very important point. Okay, go ahead. Saurabh, it's all right.
Okay, sir. No any abnormal finding in cerebellar examination. No any abnormal finding in
I think
spine.
rather than that, what we should say, cerebellar signs absent.
Okay.
You know, how we are putting it is also very important. No any abnormal finding on cerebellar examination. Rather than that, you can say that the cerebellar
sign is...
Or similarly, no signs of meningeal irritation or signs of meningeal irritations absent. You know, how we are putting in the language, that also makes difference of our palatability of the presentation. Meaning is same, but still it makes difference in our presentation, right? Okay.
No sign of meningeal irritation were present. There are no any abnormal findings in peripheral nerve examination.
So what are the conditions you get a meningitis without a meningeal irritation? So we'll ask questions like that.
Yeah.
So what are the conditions you get?
Aarti, you can answer. Sir says that the signs of meningeal irritations, suppose you got it positive, but it's not the case of meningitis. So in which other conditions where you may get the signs of meningeal irritation present? Which are the conditions? There is no meningitis, but still signs are there.
And encephalitis.
Okay. Anything else?
Brain abscess, sir. Any space occupying lesion.
Why this space occupying lesion will give rise to signs of meningeal irritation present?
No, sir. No.
What is the mechanism? What is the mechanism? Can it be any other, suppose like aseptic meningitis? Can you give some examples where aseptic meningitis will be there? That means CSF is normal, or maybe some mind changes, but still, that means there is no meningitis, but still signs of meningeal irritation are present.
So
Some non-even CNS conditions can also give rise to signs of meningeal irritation present. Can it be in a case of pneumonia? Right upper the pneumonia, have you heard that you may get the neck stiffness present?
Yes, sir.
What is the explanation? Why it happens so? What do you call it? You may not call it exactly the signs of meningeal irritation, but what do you call it? And what Dr. Anand said, the series of questions may come in this direction. What is the meningism? In which condition? Whether any local cause in the neck can give rise to the signs of meningeal irritation present? Whether any spasm of the muscle can give rise to this? So all the, even occasionally tooth abscess can also present with these. Even the cervical vertebral malformation can also present in this way. Right. Even a case of the right upper zone pneumonia can also present in this way. Even Kawasaki can present with this. So I think what sir wanted, that you should know even the conditions where probably may not be the meningitis, but still signs you may get it. And then you should have the probable explanation, probable mechanism, and probable cause even. So I think if you want to go for the good performance in the exam, these are going to be the very common questions. Anyway, I think it's a good beginning. In the future, we'll be having the more regions to discuss. You can take it further, please. Saurabh?
Yes, sir.
You have any further presentation? Because we have to keep in mind timing also.
Sir, other system examination were normal.
Okay.
Yes, sir. And investigation.
Sorry. So I will interrupt here for 2 minutes. So any positive finding in history in your case? CNS. After patient gained consciousness, your examination bedside.
No, sir.
Is there any? No, sir.
Patient CNS examination was completely normal after gaining a consciousness.
So after a history, your differentials would not be like clear. You are at same stage where you are at history, or you get something. You will be clear?
Yes, sir.
No. So what I'm asking, at the end of history, we have a diagnosis of some seizure which is happening from sleep, which is we are not sure focal or generalized.
Yes.
Right now, after an examination, what additional information you get? That this seizure is acute symptomatic, or it is part of some chronic underlying process from your history and your examination. What do you think? You're not sure, still not sure.
Yeah.
Still not sure. Okay. So you are still not sure. It could be just some hypoglycemic seizure. It could be some epilepsy seizure. It could be some brain abscess seizure. You are not sure. You are sure that there is no focal neurological deficit.
Yes.
You are sure that there is no signs of raised ascites. You are sure that there is no fever, acute condition, no meningeal signs. So you are not dealing with meningitis, encephalitis. You are not dealing with strokes. You are not dealing with. So lots of things are clear. Like normal examination, we also give you lots of answers.
Yes,
so your normal examination will rule out lots of diagnoses. Like acute infective etiology is ruled out. Your strokes are ruled out. Your so these two things are at least ruled out.
Meningitis ruled out.
Yes, so all infections. So infections are not there, at least acute meningeal and meningitis encephalitis is not there. Just strokes are not there. But you are not sure what is it. So normal examination with first seizure. So here, if you put it in a syndromic way, like in CNS, what we approach is always clinical. So this is the first unprovoked seizure, and now you have to investigate. And you're not sure about your focal or generalized onset. Okay, so this is a first unprovoked event because there is no any provocation out of sleep. So first unprovoked event, which is seizure, which could be focal, could be generalized. It is up to investigation to decide, or up to next seizure to give the answer. Okay, so after examination, your clinical syndrome is first unprovoked seizure, unknown onset, under. Hello. So my diagnosis after this history and examination would be in my clinical notes. I write first onset under investigation. Okay.
Yes,
I
sir.
think,
Baldev, sir, you want to add anything or?
No. I think Dr. Ritesh has pointed out very important. Please keep in mind for the postgraduates, and I will say all of us, even clinicians, that in the CNS, it is said that more than 80% diagnosis should be revealed in your history. At the end of history, many times some examiner will ask you even that what you are expecting positive findings on CNS. And purposefully, I think you should very specifically verify your findings on CNS examination. And at the end of this history and CNS examination, we should have the very distinctly clinical diagnosis. Of course, clinical diagnosis is very important. I will say Dr. Ritesh has mentioned, please keep in mind, many a times you have to keep it some syndromic situations. We may not be able to point out very specific, but at least you can rule out something that suppose, is it possible some acute inflammatory condition? Is it possible some space occupying lesion? Is it possible some degenerative disorder? So you may keep it some syndromic condition. Suppose, okay, then out of that, which one may not be clear. And when the CNS is totally, examination is normal, very, very rightly, Dr. Ritesh said, that also contributes a lot, because out of your thought process, several conditions, many of them you can say that now less likely. Then very prominently we can say that what is more likely, and that you can put even the possibility. And very rightly, Dr. Ritesh at the end mentioned, suppose if you don't have even the answer, many times it happens so, even in spite of history and examination, then you can find out that what was the presentation. And for that presentation, still you can keep that it is under investigations, keeping in mind various possibilities for this reason, I will plan for the investigations. Yes. I think that should be the answer.
Yes.
Anyway, now gradually we are reaching to the end of time. So should we go for the investigation, Dr. Anand, whatever they have performed?
So I think there's no meaning of further discussion on investigation. So we'll, once again, you have to solidify your history taking, not only history taking in a proper way method, all from presenting complaint to till the last of the history, socioeconomic status, it means in an orderly way. And each and every history, you see that it is helping your clinical case. Here, if you got a neurology case, how it will help them. Then at the end of history, you sum up your findings. Then you go to examination finding, again neurology. So in an orderly way, we already discussed all these things. And also at the end of examination, what is your clinical diagnosis? Then we go, because 80%, 90% you get diagnosed by history and the clinical examination. 10-20% your investigation may help. But in this case, it's something. So that presentation is very, very important. Here, investigation, we are not going to see anything because EEG you are not supposed to read. You cannot read EEG. MRI, it is okay. For clinical purpose, now we are also doing it. And finally, you are diagnosed, what is this one? So don't get biased like here, your treatment, whatever it is not least important. For patient, it is important. For our examination purpose, it's not important. So once again, Saurabh will present another case after 6 months. And with all your all correction and Prajapati sir should say good Saurabh like that. Because we have to change. Here class is for discussion, as I agree. And also one thing you can do, I think my personal experience, you can present the same case in front of your colleagues there, so that you can improve. Because here it is all India people are watching it, so you can improve it by presenting it. This is my simple. And I have to attend another meeting. So
I think Dr. Anand has given the good suggestion to all the postgraduate, particularly exam going. Make your group. And I will say, alike student, then you can find out these types of interesting case. Some can prepare, and even with your teacher or senior resident, or even among yourself, you can discuss. Because I remember Dr. Anand and all of us done the same thing in the past, almost 40 years back. That for your kind information, Dr. Anand has done the post-graduation from Surat. And he is very familiar with even our setup also. And besides all these issues. And very rightly he said that for good learning, for the examination, we'll have to discuss it out. You may be knowing, and unless you do multiple times presentations, naturally one cannot be confident. So I think it's a good advice to all the students. Do the multiple times. If not even, I will say, suppose this is a PG clinic among yourself or with some resident friends or even the teacher. But I think that exercise really is quite rewarding, I
think we can conclude it here. Nehal madam, for Yogesh sir.
Yeah. Yes, sir. So thank you so much.
I think, Nehal, before that, anything in the investigations if he has done, Saurabh, we can just show for a few minutes, then we'll go for winding up this session.
Sir, Anand sir has another meeting, so let me thank him in his presence.
Yeah.
So
Okay.
After that, we can continue with the
Yes.
So, sir, thank you so much. You are always there in guide the students.
I am very sorry. I have not hurt anybody. It is not my old person's perspective. I don't want to hurt anybody. It is our
Dr. Anand, on the contrary, I will appreciate. Particularly, I will say, I know he's a master clinician, but more specific in the CNS. And even it's whenever he's there, it becomes, I will say, good learning session for all of us. Certainly, and I think many points you have pointed out. I understand students are also, our aim is not to make you nervous, to encourage you, to sensitize you, to draw attention, and so that at least in the future our performance can be good, we'll lessen the mistakes. And I'm sure that in that way, Dr. Anand's comments and I will say his points are very well. Thank you very much, Dr. Anand. Very nice.
Sir. Thank you, madam.
Thank you very much, sir.
Saurabh, just you can mention what are your findings and then we'll go for concluding the session.
Routine investigation was normal. CSF examination was also normal. MRI brain. Well-defined ring enhancing lesion measuring 1.2 into 1.1 into 1.1 centimeter in left basal, basifrontal, cortical and subcortical region with mild to moderate perilesion edema, sir. And another similar ring enhancing lesion measuring approx 0.9 into 0.9 into 1.1 centimeter in right cerebellum on the lateral aspect with minimal perilesion edema. Sir, it's a colloidal vesicular stage. The finding represent infective granulomatous lesion and most likely to neurocystic sarcosis.
I hope that Dr. Ritesh is there.
Yes, I am here, sir.
I think, Dr. Ritesh, you are the better person to interpret these CT findings, and even for the sake of the students, that
yes,
how to differentiate the ring enhancing lesions, particularly NEC and even tuberculomas and some secondaries and some other condition. I'm sure this is also important point for them. Please, you can take it.
Yes. So basically, apart from MRI, Other investigations are practically irrelevant here. So we'll just focus on MRI. So MRI is showing, just a second. Sorry. So basically, there are two ring enhancing lesions here. So first of all, any ring enhancing lesion, there are 3 to 4 common differentials. Okay, we all know that. One is neurocystic sarcosis, one is tuberculosis. In immunocompromised ALL, all these patients could be fungal, and some bigger size brain abscesses. And the other common differential which we all are missing many a times, and which we are seeing more and more now, is lots of demyelinating conditions also present with ring enhancement. So demyelinating plaques, like MOG antibody and lots of other demyelinating neurological disorders nowadays, we are seeing a lot more than previous. They can also have sometimes irregular ring enhancement, not complete, but they may have some ring or disc enhancement in lots of demyelinating conditions. So differentials would be infective and demyelination. So amongst infective, the two most common are neurocystic sarcosis and tuberculoma. So it is a common debate. All radiologists always write mixed opinions, and they write correlate clinically. Very few like bold radiologists will write perfect diagnosis. Many times they keep it open for us to decide whether it is neurocystic sarcosis or tuberculosis. So I will tell you a few points, 3 to 4 very important points. You can easily differentiate. I think in 99% of cases on basis of imaging, we are sure that whether it is neurocystic sarcosis or tuberculoma. First point, location. Location is very, very important. Cortical subcortical junctions commonly are neurocystic sarcosis, while deep lesions, basal ganglia lesions, deep lesions are more of tuberculoma. First point. Second, size. Subcentric, like 1 centimeter, 1 by 1, 0.9 by 0.9, 1.1 by 1.1, something like that, around 1 centimeter. Subcentric or just around 1 centimeter, they are more likely to be neurocystic sarcosis. While bigger ones, 2 by 2, 3 by 2, 4 by 4, they are like brain abscesses or tuberculomas or something like that. So size is again important. Third important thing is edema surrounding the lesion.
NCC.
So if edema is mild to moderate, it is NCC. If it is moderate to severe, here it is a gray zone. But generally speaking, in NCC, the edema is mild to moderate, while in tuberculoma, it is moderate to severe. So that is the third point. Fourth important point is, if you can see the Scolax, which is primarily seen in CT, but in MR also now, gradient echo images and lots of images, you ask your radiologist.
I think Ritesh connection is lost probably.
Likely to be while your conglomerated lesions, 2-3 lesions together, they're all their borders are intermingled and all these things, more likely to be tuberculoma. So these are the 3-4 common points for you or as a pediatric resident. There are lots of other important detail points which is for radiologist or for a neurologist. Like one point I'll tell you, which is important, which you can all remember also. What is the pathology in neurocystic sarcosis and what is the pathology in tuberculoma? So in neurocystic sarcosis, there is a cyst. We call it as a cyst. Cyst means fluid. And in tuberculoma, there is a caseation or necrotic material inside. So in neurocystic sarcosis, you see the clear water inside the lesion because it is a cyst. So CSF intensity will be there inside the lesion. While in your tuberculoma, the intensity will be totally different. It is not the CSF intensity. It is a caseating material, necrotic material. So in neurocystic sarcosis, there is always T2 hyperintensity inside the lesion. Like same like CSF. What you see in CSF, same intensity will be there inside the lesion in neurocystic sarcosis. But in tuberculoma, it is different. So it is a simple point. Exactly same like CSF inside the lesion, neurocystic sarcosis. Something different than CSF. And all other points are, you're not sure, go towards tuberculosis. This is little detail, but it is very simple to remember if you remember the pathology. So I think these are 4-5 points.
Doctor, is there anything from the numbers of the lesions point of view?
Yes.
I think again there is some problem with his net.
Sorry. So if it is single, more likely to be neurocystic sarcosis. And if it is multiple, 5, 10, 15, 20, fungal, demyelination, tuberculoma is not very large in numbers. They are, I think, 2, 3 many a times. So numbers is again important. Single, more likely to be NCC. But tuberculoma could be also single. So that will not differentiate, but that will help to, like, one of the point which favors neurocystic sarcosis, numbers.
I think let me appreciate the so distinctly Ritesh has, I will say, described. And for the postgraduate, this is very common question. Maybe even the theory, the short note that reading enhancing CNS lesions, or even in the practical examination, there may be some CT scan, or suppose these type the case, they may ask you. So I think this is very common for all of us. And so distinctly he has mentioned the points, even easy for us to remember. That NEC, he said that the most of the time they are these superficial lesions, cortical lesions. Tuberculomas are usually deep or basal ganglia lesions. Second, he said very importantly, he verified the size of the lesion. That sub-centimeter smaller size is more common in NEC, while in a case of larger size, other differentials. Third point, he's very rightly said regarding the edema over the lesions. Further, he said even the density of the lesions, that in the cyst there is a thin density, while the caseating material are having they are the granulomatous even, therefore the different lesion. Even numbers of the lesions is also very important, that usually single lesions or very few lesions are favoring the NEC. Multiple, probably more of tuberculoma, but even still more, 10, 15, what he said, maybe even, I would say, drawing our attention towards rare conditions like degenerative disorders or something like that. So I think these are the so many distinctive points he has mentioned. Please, I'm sure that if you remember, it is going to be quite useful, not only in the exam, in our daily practice also. Thank you very much. I think Ritesh, you have done a very good, wonderful job. Even I also learned a lot from this
No,
discussion.
sir. I am your student.
So Saurabh, now anything with you, or I think we should end over here because already we have overshooted the time. Okay, I think management point of view, just you can just describe whatever you have. Something probably new, then I think Ritesh will add. Then we'll end. You can take some 2 minutes.
Sir, general measures like
Anyway,
temperature.
I think rather than Saurabh, let us learn from Ritesh. Ritesh, can you just very specific treatment can you mention at present what is recommended?
Yes, so I think yes, everybody is sure that this is NCC and we are going to treat it. So there are 3 things. One is seizure management and one is infection management. Seizure management, we give anti-epileptics. Whatever you give is fine. You are loaded with something, you can continue with whatever you want. But carbamazepine, naptoin, valparin, levetiracetam, anything is okay. So there is no specific choice. Whatever you are comfortable, you just give it for few. The duration of anti-seizure medication here is always a dilemma. So what we do, we usually give it for at least 6 to 12 months. So now 6 or 12 is a question. I nowadays give for 12 months and I repeat MRI after 9 to 12 months. And if your lesion is healed completely or it is healed by calcification, there is no edema, then you can stop your drug. Simple about anti-seizure medication. Preferably carbamazepine, naptoin, something like that. Give it for 6 to 9 to 12 months, whatever you are comfortable. My comfort range is 9 to 12 months. And repeat your imaging after 9 to 12 months. If it is normal or calcified lesion is also healed lesion. So no need to continue on basis of calcified lesion. So continue your is the first lesson about anti-seizure. About anti-helminthic. So there are you need to give steroid. So steroid you start, and after steroid you start your anti-helminthic drug on second day. Suppose you are starting steroid today morning, then start your next day night dose. After 2 days of steroid you can start. Various people are saying 3 days, 4 days, 1 day, 2 days, lots of debate. But I usually do start steroid on 1 day and next day night I'll give albendazole. So that is just keep a gap of 1.5 to 2 days. Steroid you can standard use Visalon, our Omnacortin, and give it for around 15 days. So 7 days full dose and then tapering, or 5 days 3 tapering, whatever you are comfortable. Regarding anti-albendazole, there are 3 schedules, 7, 14, and 28. I am following 14 right now. There are various recommendations from PGI in Delhi because they are seeing this daily 10-15 patients. So there are lots of studies from PGI regarding NCC. And they are recommending, AIMS people are recommending 7 days. Few are recommending 28 days. So anything is okay. I give 14 days. All three are 80 14 days, days, AED for 6 to 9 months, and then you can stop the AED. This is my protocol in these patients.
Okay. I think, thank you very much. We have to end over here. But Ritesh made the two last points very distinctly clear regarding this ring enhancing lesion and particularly the management protocol for the NEC. Of course, there are some different regimes are there, but I think whatever one you are following, I think it's all right. It's not wrong. So thank you very much. We have to end over here. Dr. Anand already left due to some other prior commitment. But Dr. Ritesh, thank you very much. I will say, with your clarity of point is very important. And all these students, and Dr. Saurabh, always you know that the presentation is a good exercise. Don't get it discouraged. On the contrary, this is good.
Yes.
And I understand that you want to put it on the as a younger person, it's always very important to learn. All other students, Arti and what you are able to read, Dawal and Rashmi, I think go for the multiple presentations. That's a good exercise.
Yes.
And try to do it very methodologically. Ultimately, it is quite rewarding. Thank you very much, Dr. Nihal and Dr. Yogeshwai, for organizing this type of the PG clinic and giving us the opportunity. Thank you very much. Over to you, Dr. Nihal.
Thank you so much, sir. Yes, we learn every time from the students also, and students learn from us also. And whenever they present, they learn definitely. So I hope the students have learned today how to present, what are the points to how to arrange the presentation, and what are the points to be there in your presentation. So happy learning every Saturday. And thank you, Ritesh Bhai, for concluding with such a great remarks and telling us distinctly that what should be there in the presentation and how you should proceed. Thank you so much. Thank you so much, Baldev sir, also.
Thank you.
Thank you, everyone.
Good.
Thank you.
Thank you very much. After the long journey, you have joined.
Thank you, everyone. I have some certificates to show. So with all your permission, shall I proceed with that?
Yeah, sure.
Okay, thank you. Dr. Saurabh, could you please stop your screen sharing?
Yes.
Thank you, sir.
So thank you, Saurabh, for presenting the case.
Thank you, ma'am.
Oh, Dr. Yogesh Bhai is also saying, thank you very much, Yogesh Bhai.
Thank you, sir. Thank you. Thank you.
I thought that you may be busy at other places.
Yeah.
I thought that you may be busy with some other.
No, sir. I'm continuously here. In between the rain started, so lights off.
Right.
Otherwise, I was fully in the case discussion.
No, but I think it's going on very well. Very well. Thank you very much and good night. Good night.
All of you, because of you, sir, only. Thank you, sir. Thank you.
Okay.
Thank you,
Okay.
madam.
Thank you, sir.
And congratulations, Saurabh. Carry on. Huh?
Yes, 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 yes.
Thank you.
Ritesh,
So thank you, Clarinet, for giving us this support. We can now end the session.
Thank you so much, everyone. Thank you for giving us the opportunity to host the session, and hope to have you again on our platform very soon.
Shreyanshi, just one suggestion. Put
Yeah.
the name in the bold letter with a different color of the presenters and the faculty. Huh?
Okay, sir. Sure, 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 sure. Sure. Thank you for the suggestion, sir. Thank you.
Madam, આવજો.
Good night, everyone.